Hello everyone. Good evening, good morning, good afternoon, wherever you are. This is Dr. Tristan. My apologies, first of all, for the delay in posting this week. Managing a full-time private practice, as well as an exploding podcast, keeping myself and my animals alive and my house in order. It's been difficult, but I'm back. And there's going to be 2 episodes coming. The first one we're going to chat about now is the comprehensive management of congenital diaphragmatic hernia, a journey from embryology to neonatal care. This is the next episode in Dr. Tristan Anesthesia Tutorials, our series on pediatric anesthesia, and our specific focus on neonates and neonatal anesthesia. So, thank you to those of you that have checked in to see if I was okay. I really appreciate it. And as I said, I'm sorry for the delay, but let's get going. So Dr. Tristan Anesthesia Tutorials is an educational podcast intended for medical students, anesthesia trainees, as well as specialist and GP anesthetists across the globe. We are available in English, Hindi, Mandarin, French, and Spanish, with Arabic and Urdu soon to be added. Use those QR codes on the screen to like, share, subscribe, and that is on youtube.com/Dr. Tristan Anesthesia Tutorials, patreon.com with the same handle, and as you see there, Dr. Tristan Anesthesia Tutorials, which is at Dr. Tristan Tutorials on TikTok. You will find free content on TikTok and YouTube. You will find the first 5 episodes of the podcast in full for free. And if you wish to subscribe for full content to the rest of Dr. Tristan Anesthesia Tutorials, which also includes show notes, it includes journal articles, it includes Ask the Expert sessions, Ask Me Anything, CPD or CME accreditation, depending on your country. Please go to patreon.com for more information. We are adding Substack, YouTube Music, Hubhopper, as well as platforms in Asia very, very soon. And our website will be live in the next 7 days. This is an incredibly exciting time for me and for all of you guys. I just want to say thank you again. In our first month, we were seen by an incredible 8.5 million people across the world. In particular, I would love to thank the community on TikTok for 5.5 million views and 7.5 million impressions. My loyal subscribers on Patreon, thank you so much for subscribing. We are already at almost 40 members on our Patreon community. It is rapidly growing. And on on YouTube, we're at 2,500 subscribers and growing. We're at 40,000 views. And on Facebook, Meta, Instagram, we're at another 1 million impressions. So the fact that 8.5-9 million people have heard my voice, seen my face, and heard me say a little bit about anesthesia and talk about the passion that I have for this field and the passion that I have to educate not only the medical community, but the broader public with my Dr. Tristan Asks the Expert sessions. It is humbling, it is gratifying. I am here for you guys. I'm hiring staff rapidly to assist me. I'm getting a very, very cool social media manager. So don't worry about graphics and things. That's all going to be looking beautiful, guys. And from me, Dr. Tristan, I'm going to be sticking to producing 12 hours of content a week. Remember, we are adding basic sciences as well from September, Tuesdays and Thursdays, physiology and pharmacology to start off with. And I will then be adding pathophysiology as well. And that will be aimed at advanced high school level, BSc, undergrad medical students, as well as for those who are doing basic sciences as part of their Part 1 or primary examinations. Let's get going, guys. Just remember, quick disclaimer, this is not medical advice. Please consult your doctor. for any medical conditions that you may have or any medical questions that you may have. For those of you that are studying, remember that every effort is maintained to make this accurate, but this is not peer reviewed and it is not edited. And so please do not rely on this solely as your only source for referencing. Consult your local experts and your local guidelines. If you are going to share this, I do not mind at all, but please make sure that you credit Dr. Tristan from Dr. Tristan Anesthesia Tutorials. So hello guys, you're going to see a little bit of a different setup here. I thought I would move things around and you could see my living room. So we've got a nice fire going, a little bit of a glare there. Maybe let's move this guy in the way there. I've got these super cool coasters that bounce up and down, but I'm going to put one of these coasters and let's maybe move. There we go. That's much better. Bit of a less glare from the fireplace. Welcome to my home. Welcome to Dr. Tristan Anesthesia Tutorials. I am Dr. Tristan. I'm sorry for the delay. It has been a crazy week. I have been laughing at myself in this house this evening. So Monday, I basically spent most of the day doing translation of the podcast into the 5 languages that we were speaking about. I then researched 3 talks and put the show notes together, put the PowerPoints together, and started doing some recording. Tuesday and Wednesday, well, I was in theatre doing multiple cases, about 7 or 8 on both days. So and including today, we did another 4. So I've anesthetized over 20 patients in the last 3 days, and I've only been getting home at about 8 p.m. So I am sorry for the delay, but as I say, things will get back on track from next week. And this is releasing, it's now it's just gone into Friday, the 22nd of August in South Africa. And so this will be the first episode for Friday. There will be a second episode on tracheoesophageal fistula. And there will also be the edited version of my live with Dr. Teboga Tabane, if you didn't catch us live. So much, lots coming, guys. I'm here for you. I promise you it's going to be an absolutely great weekend with Dr. Tristan. So what are we going to talk about today, guys? We're going to talk about congenital diaphragmatic hernia. And essentially, I want to take us on a journey from the NICU to from the embryo to the NICU. So essentially, basically the aim here is we're going to guide you on a journey from the embryonic development of the neonate, in particular looking at the embryonic development of the diaphragm and the lungs. And we're going to focus on the complexities of managing congenital diaphragmatic hernia. And we're going to focus obviously on the anaesthetic points, and we're also going to talk about the critical stages from embryo to birth and the immediate perinatal phase, as well as then focusing on the theatre and the NICU. So guys, just to give you a little bit of personal experience and perspective, for some reason, I always used to get allocated to neonates. I really loved it. As I've said to you before on the channel, I do a lot of neonates. And the smallest baby that I've ever anesthetized was 678 grams, and that child survived with very minimal neurological injury. So very, very proud of that. And I'm just going to move my head a bit, yes, so that the light is not so bright. That's better. So I have anesthetized, I've lost count of how many kids with NEC. In terms of congenital diaphragmatic hernias, well over 20, I'm sure. Same with tracheoesophageal fistulas. So these are super challenging. When you get a premature baby with NEC, a CDH or a TOF, this is what I call big boy anesthesia or big girl anesthesia. In South Africa, there's a phrase, I'm sure it applies to a lot of Commonwealth countries, it's time to put on your big boy pants or your big girl pants, and this is certainly one of those cases. So let's get going, and hopefully you'll enjoy this trip with me. So the diaphragm is a muscular structure, and essentially it occurs when the, excuse me, let's go back, there we go. So the normal diaphragm, it functions to support breathing by creating a pressure gradient. There's no openings that are present, and essentially the only opening in the diaphragm is at the level of the thoracic outlet, where the esophagus, the blood vessels, thoracic ducts, etc. Okay. Lung development occurs as the diaphragm grows. So it's the development of the lung that pushes the diaphragm and allows it to grow downwards and keep a separate structure from the abdominal cavity. So in congenital diaphragmatic hernia, essentially you've got an opening in the diaphragm, okay? And there's a developmental defect. And most commonly, it's on the left-hand side, which means that the stomach, maybe spleen, and often small bowel, sometimes even large bowel. But if it's on the right side, the liver, the gallbladder, and bowel, and the herniation disrupts lung development. And essentially, it becomes a vicious cycle. So it starts off with abnormal lung development, allowing the hernia to start. And what then happens is that then the abdominal organs impair lung development, the hypoplasia, then leads to the persistent pulmonary hypertension of the newborn and all of the respiratory and cardiovascular issues that we're going to discuss during this talk. So what is the scope of this globally when we're looking at morbidities and mortalities and the cost? So if we're looking at sort of global figures and some US incidences and data, globally it's about 1 in 4,000 live births. So it's not insignificant. If you consider a condition such as trisomy 21 is anywhere from 1 in 1,000 to 1 in 3,000 live births. And remember, the incidence of congenital cardiac disease, as we spoke about before on the channel, is 1 in 1,000 to 1 in 3,000. So it's just slightly less common than those. In Europe, it's about 1 in 3,600. 85%, as I said, will be on the left-hand side. And on the left-hand side, it means that you will get most likely stomach, small bowel, and large bowel. And that's what I used to see most commonly. Out of all of the cases that I've done, the over 20, I've only done 2 right-sided. And those were the sickest kids that had the poorest outcomes because they had a massive part of their liver in the chest, which is an issue. In terms of the economic impact in the United States, it's at least around $250 million. And so if you can extrapolate globally, if you look at the burden of neonatal healthcare and neonatal prematurity and morbidity and mortality, which we're going to discuss next week with a good friend and colleague of mine who's a pediatric surgeon, it is in the billions worldwide. And unfortunately, no matter how good we are, depending on the severity of the lesion, you're looking at a mortality of up to 30%. In developed countries, the mortality is approaching closer to 15 to 20%, depending on the severity. In South Africa, it's about 20 to 30%. And then, unfortunately, in areas of Africa, the Far East, certain parts of South America, the Caribbean, etc., that have got majorly deprived access to healthcare, there is then a even higher mortality rate, unfortunately. So what are we going to go through? Starting off, we are going to go through. So we're going to look at the etiology and the pathophysiology of CDH. We're going to look at diagnosis in utero and prognosis, and look at the specific features that affect morbidity and mortality. We're going to look at both prenatal and postnatal care and management. We're going to talk a little bit about fetal surgery and anesthesia and the role of fetal surgery. And then we're going to talk about the neonatal anesthetic management of the surgical correction, which is much more common. So what is the etiology of congenital diaphragmatic hernia? So essentially, the etiology, as of all things, is multifactorial, and it is based on genetic factors. So there is a lot of association with trisomy 13, 18, and 21, which have a higher association with CDH. Mutations in the WT1 and the Ku genes as well are also implicated. So there may be genetic factors that are causing the issue. Then obviously, as with anything that happens as an in utero embryonal development issue, an iatrogenic or congenital issue, environmental issues. So herbicide exposures, neurofen exposure, perhaps certain ACE inhibitors, beta blockers, etc. Thirdly, nutritional disturbances are a major issue causing CDH, especially in lower socioeconomic countries. And essentially here, it's the absence of vitamin A in particular that has been associated with CDH, and low retinol levels as well. And then just remember, guys, don't forget about the associated syndromes. And we're going to keep talking about this when we do CDH, when we do TOF. I'm going to then do an episode on neonatal airway conditions. So we're going to talk the Pierre-Robin sequence. We're going to talk Treacher-Collins, Beckwith-Wiedemann syndrome, all of those things. So syndromes like Fryns syndrome, Cornelia-de Lange syndrome, Beckwith-Wiedemann syndrome, and essentially there are a host of very rare, we would call so-called orphan anesthesia conditions where there's very little research on them. So if you have a child with CDH, the absolute first rule, and this is something that is non-negotiable, is that if you have a child with CDH, they have to have a cardiac echo, they have to have a cranial ultrasound or a CT scan, they need to have a babygram x-ray to look for spinal cord abnormalities, and they need to have a kidney ultrasound. You need to look for ASDs, VSDs, AVSDs in particular, but tetralogy of Fallot, and we'll talk about my TOF with a TOF when we do the talk on tetralogy, on tracheoesophageal fistula. It's one of my most intense but proudest anesthetics that I've ever done. Was a baby who was 1.8 kilos with a tetralogy of Fallot and a tracheoesophageal fistula. So it's possible. I have done half a dozen CDHs that have had ASDs, VSDs, AVSDs, or PDAs. Luckily, I've never had a cyanotic with a CDH. I don't even want to imagine, oh my word, what that would look like. It actually makes me feel a bit nervous thinking about it, because imagine the pathophysiology of that. You've now got a cyanotic condition causing pulmonary hypertension, and you've got CDH, which has lung hypoplasia causing pulmonary hypertension and hypoxia. Maybe those two aren't compatible. Make a comment down below if there's strong associations, or what the survivability of CDH is with cyanotic congenital hearts, and I'll also have a look after this talk and get back to you. Interesting question. Love it. So guys, just remember that any child, any neonate who's born with any one congenital abnormality, you have to rule out all the others, and the most common ones and important ones for us to rule out are airway issues such as laryngo or tracheomalacia, or upper airway issues such as a Pierre-Robin, Beckwith-Wiedemann, etc. We need to worry about cardiac issues. Okay, they must have an echo. We need to worry about spinal cord and spine abnormalities. They must have a babygram. And we're worried about renal agenesis, horseshoe kidneys, or renal failure. So you must rule out other congenital abnormalities, please. If we look at the embryology quickly of the diaphragm, it's formed around 12 to 16 weeks of gestation, and it develops from the septum transversum, the pleuroperitoneal folds, and the esophageal mesentery. Essentially, what happens with a CDH is you get a failure of fusion of these components, and this failure leads to a defect in the diagram. So you can imagine in the diaphragm. So you can imagine, for example, if you have three components of the diaphragm, okay, and those three components are meant to all, if you look at this page, so you've got the the mesentery here, you've got the septum transversum, you've got the pleuroperitoneal folds, etc. And essentially these all start off like this. They are supposed to spread, and then they are meant to form the full diaphragm. However, if one of them has a failure of fusion, for example, you then have a situation like this, where there is a defect, and as my face comes through, imagine that this is now a bowel contents coming through into the abdomen, and this is stopping the development of the lung, as well as causing direct pressure on cardiac structures. So it's a fusion failure, basically, same as in the heart. Okay. We will be doing a talk on embryology relevant to anesthesia next week. There's then also the dual hit hypothesis. So essentially what happens is, number one, you have the lung hypoplasia, all right? So it makes sense, we've spoken about that. There's an issue, congenital, environmental, genetic, chromosomal, and you get bilateral lung hypoplasia, and this initial insult sets the stage for further issues with lung development and with issues with the diaphragm, okay? So the second hit, you get abdominal herniation. So now what's happened, as we've said, is you've got the defect, but if there was no abdominal contents, there was going to be nothing to push through that defect. It wouldn't get so big, but it gets bigger and bigger as the abdominal contents of the baby gets bigger. Remember, as a baby grows in utero, it swallows a lot of amniotic fluid that goes into the stomach gets bigger, the bowel is full of fluid. As the baby comes into the world, it starts to breathe, the lungs expand, so there's less space in the chest. As the baby is fed, if this is not noticed, or the baby even just swallows air, as we all do, that air bubble that's at the top of your stomach, I'm sure you've all seen it on a chest x-ray, it sort of sits here. Air goes up, guys, so it's going to pop up into the chest. And it's very, very disconcerting to see a stomach bubble sitting under the left clavicle, but I've seen many of them in my time, okay? The pathophysiological consequences are that is we've then got reduced bronchial branching and thickened pulmonary arteries. Remember that your bronchioles and your alveoli are meant to be this fine, fine mesh that is so fine that one red blood cell at a time goes through the capillary in the alveoli. That can't happen in this situation. Clinically, what does that then lead to? Well, it leads to the vicious cycle of persistent pulmonary hypertension of the newborn. So what that means is that the child is born and immediately develops respiratory failure within the first normally 6 hours of life, sometimes at birth. If there's a cardiac lesion associated with it, or if they're very premature, or if they've got another airway issue, such as a tracheal web, laryngeal web, or like I said, a tracheomalacia. A lot of them, however, it's after the first feed, and all of a sudden the bowel is now full, it starts having peristalsis, and unfortunately, then the baby goes into distress. So it can be, if it's not picked up in the prenatal period, these kids can have a massive insult because they will have a sudden respiratory distress, sudden hypoxia, sudden onset of cyanosis, perhaps bradycardia, perhaps apnea, perhaps even, God forbid, respiratory or cardiac arrest. And nobody will really know why, because we're not thinking that there's a congenital issue. And unfortunately, just from a very practical point of view, when it comes to all congenital issues, so TOF, CDHs, hearts, other rarer things such as cystic hygromas and all of those things, the reality is that unless people in South Africa are on a medical aid or have the means to afford it, ushering a pregnancy in the private sector here will cost hundreds of thousands of rands without medical insurance. So people do not get fetal ultrasounds. They do not get fetal medicine scans, 4D scans, unless they're in private healthcare or they have the means. And I'm sure it's the same globally, whether you're in the United States, whether you're in India, whether you're in Japan or China. And so as such, a lot of these kids are born and, they have a gastroschisis or an exomphalos, what we call an omphalocele, either way. They have a CDH or a TOF, or, they have a spina bifida, for example. and we didn't know about it. And it's the lack of preparedness, the fact that they're born in a clinic and not a hospital, the fact that they're born at a rural hospital instead of a central hospital, all of those factors increase their morbidity and their mortality, unfortunately, before they ever see an anaesthetist. So what are the most common associated anomalies? Number one. I just can't emphasize it enough, guys. It's cardiac defects, okay? They have to have an echo, okay? Up to 14% of them can have cardiac issues. In my personal experience, sample size of 1, I found that about 20% of them, 1 in 5, minimum. Chromosomal abnormalities, add to that about another 10 or 15% of them have got trisomy, especially 18 and 21. Syndromic issues, I've seen a few Cornelia de Lange syndromes, I've seen one Frein syndrome, I've seen a couple of Beckwith-Wiedemann's, I've seen a couple of Pierre-Robin's, and so you need to think of that. You then also need to think of what we call the vactral abnormality, a so-called structural anomaly syndrome. And in this instance, this is affecting up to a third of all children born with CDH. And this includes issues with the vertebra, anorectal malformations, they may have a cloaca, they have esophageal atresia, they have retinopathies, they have limb abnormalities, and they have CDH. So we're going to talk about that in a minute. And we will then look at them in more detail. So how do we classify the severity of congenital diaphragmatic hernia, guys? This is very important because the survivability is obviously linked to the severity. And remember, we're going to go through this again when we do the general presentation for anesthesia for the critically ill neonates, just as a general principle, and then we'll focus with that one onto NEC. And that'll be with our ped surgeon next week, Wednesday. So remember to like and subscribe, hit the notification bell so you don't miss out. And if you go to Patreon, you certainly won't miss out, and you'll get live access to that session with him next week. Anyway, back to the show, the episode. And so essentially, guys, when you're looking at babies that are born that are premature, it's quite obvious, but we're just going to run through it again. Obviously, number one, the level of prematurity. So the number of weeks that they're born at will determine survivability and morbidity, okay? Number two is their birth weight, okay? Number three is then the presence or absence of congenital defects. And so if they have one, then their survivability decreases. If they have two, it decreases further. And if they have three, or they have strange syndromes or a very abnormal defect, and you'll have a look now at the, I'm just looking at the beautiful imagery on my TV in the background, sorry. Okay, so defect type A has got the highest survival, and these are small defects surrounded by muscle. And these are very easy because for these, they sometimes are even called diaphragmatic eventration rather than diaphragmatic hernia. So essentially, it's eventration is a weakening of the diaphragm, but there's no actual herniation through. So there's still a membrane there with muscle, and essentially a patch is sewn over that. Or in this instance, if there's a small defect, a patch is sewn. It's sewn closed primarily, and then a patch is sewn underneath it to reinforce it. These go pretty easily. They do well. Bob's your uncle. It's just do a normal, safe anesthetic for a neonate. Nothing too fancy. Type B is the one that we will struggle with a lot more in theatre. Type C and type D, it then becomes huge issues. So type B, there's moderate tissue absence. So less than 50% of the tissue is absent, okay? Survival rates are lower, okay? But still approaching 90%. Sorry, I didn't say for a type B. A type A, survival should be 95% or above. For a type A, it's about 85 to 95%. For a type C, this unfortunately means that more than 50% of the tissue is absent, okay? And these have got a significant impact on life expectancy and prognosis. And you're now starting to look at 60 to 70% survival. And then you have the most severe, a type D defect, where there is complete agenesis. Now remember, if you've got complete agenesis of the diaphragm, don't forget that the more severe the diaphragmatic issue, the more severe the lung issue, the more severe the hypoplasia. So it becomes a vicious cycle, and that's the problem. So it's not just that you've got this massive defect, 50%, it's fine. They can put patches, we can manage, we're good guys, you know, with Dr. Tristan and all the tutorials we're having, and everything we're going through, and wherever whoever you're working with and being trained, you know, you're good at doing neonatal anesthesia, I'm sure, doing a little thoracotomy or a lap, it's not too much issue. The problem comes in is that if you've got an issue with the diaphragm, you've got an issue with the lungs. And I'm going to say that one more time. If you've got an issue with the diaphragm, by default, you have an issue with the lungs. And that becomes the problem, because the more that the diaphragm defect goes up, the more the lung hypoplasia goes up. And that has a terrible handshake that does not, that's a Muhammad Gaddafi, Saddam Hussein type handshake. It's not a good one, guys. Okay. So type D has the worst outcome, and you're looking at less than 50% chance of survival. How do we diagnose it prenatally? Well, in most cases, about half of them are diagnosed. In most countries, should I say, about half are diagnosed via routine ultrasound. And the most obvious is by seeing an air bubble in the chest, or not having a stomach bubble present in the abdomen, and by having a large amount of amniotic fluid. Remember, in this instance, the baby will not be able to swallow fluid effectively, as it should be doing in utero. MRI is particularly useful for diagnosing right-sided hernias. The problem comes in when you're looking at the right side of the chest is the delineation between lung, diaphragm, and liver, which literally sits with the falciform ligament against the diaphragm. Getting accurate information on an X-ray, an ultrasound, or even a CT is difficult. So often these babies will, if they're stable enough, will be sent down for an MRI to delineate the anatomy when they're born. But in the prenatal stage, fetal MRI is done. It's well known. We do it at Park Lane Radiology with Dr. Shub and the team that I introduced you to before, with Tumi and them. And neonatal MRI is a very interesting topic that we'll have a chat about at some stage on the channel. Remember that the gestational age is the key here, guys. I've told you this. So the sensitivity of diagnostic methods improves with gestational age, because obviously the bigger the neonate gets, the bigger the fetus gets, the better you can see. And there's a huge operator experience curve, and it's unfortunate that because this is rare, and because doing a lot of neonatal MRIs, fetal MRIs, and fetal ultrasounds, and fetal anomaly scans, you're going to be on a long waiting list for the really good guys, and so there is quite a high barrier to entry on the learning curve. However, with the use of artificial intelligence, which I'm using, I use Grok Heavy for part of my research and my show noting, and I then use apps such as SlideSpeak and HeyGen to assist me in making better, more visually appealing and professional looking PowerPoint presentations, as well as doing my translation work for me. We should be using artificial intelligence, and there is a movement towards it. And there'll be a talk on the channel on artificial intelligence in anesthesia, where we are versus where we're going. Fascinating topic. I've got lots to say about it. But anyway, and I think it's a brilliant thing. I think AI has, to be honest, Grok alone has, shameless shout out to Elon Musk, fellow South African from Pretoria. Thank you so much, Elon. I love Twitter for all the news, politics. It's the best source of news in the world. But Grok has changed my life. I use it to plan my schedule, plan the podcast, and pretty much everything else in between. So anyway, we should be putting these images into AI and letting them assist us to diagnose these things. There's no room for pride or old-fashioned ideas when we come here. So how do these patients present? Most commonly, as we've said, guys, there's respiratory distress at birth. and it's pretty much present in the vast majority at birth, or it will develop in the first 6 hours. We then call something called a scaphoid abdomen. So just to explain that term to you, if you imagine, excuse me, if you look at my belly here, definitely not scaphoid. You can see there's a bit of post-dinner there, okay? But a scaphoid abdomen, imagine a very thin person with a very sucked-in abdomen where it's like, it's got a sunken sort of appearance because there's no liver there, or there's no stomach there, there's no bowel there with air in it to push the abdomen out. So that's what we mean by a scaphoid abdomen. Bowel sounds in the chest. It's the most brilliant thing. I absolutely love it with interns, with my juniors. You say, put a stethoscope on the chest. What do you hear? You don't tell them anything. Just say, just listen to that baby's chest for me. And it's actually a brilliant measure of the strength of someone's convictions, okay? Because, just as a life lesson in medicine, guys, in that instance, you've got me. I'm not an intimidating figure, but I'm obviously an expert, and I'm now clearly testing you in a very light-hearted, sort of, easygoing manner. However, the person puts their stethoscope on the chest and they hear, excuse me for the terrible bowel sounds, but doctors, you'll all know what it sounds like. It's a bit of a gurgling sound, okay? And they go, and they look at me, and they listen, and they look at me, and most of them will say, there's bowel sounds in the chest. They might not click that it's a CDH, but somebody, will doubt themselves and say, I hear a murmur or something. They'll kind of, they will answer, as I said, they will answer the question that they think I was asking. When I was just asking, tell me what you hear. So bowel sounds in the chest is a great one, okay? Cyanosis from the hypoxia, they're going to go blue very rapidly if you don't do something. And we confirm this most rapidly by a quick chest x-ray. It can be done in literally 30 seconds to a minute, guys. Portable, in theatre or at the delivery unit or in the neonatal ward or in our CU. So essentially there are some prognostic tools that are important that we can look at to determine how these babies are going to do, and to give parents information on and empowering them with knowledge on what to expect. So number one, the first calculation that's done is called the observed to expected lung to head ratio, okay? So basically, just to explain this to you quickly, guys, it will be in the show notes, but it's observed to expected lung to head ratio, okay? So if you look at a baby's head, it's pretty big, all right? So if we get, okay, let's use these two in the example. So normal baby, the head should be bigger, okay, than the lungs, but not that much bigger, all right? In the scenario that we have here, okay, imagine that my lip balm is now the lungs, and you've still got the big giant baby's head on top, okay, if you look like that, guys. So the head to lung ratios increase dramatically. There's a whole lot more head than lung, okay? So when we look at what they're talking about here, we're looking at the observed to expected lung to head ratio. And if this is under 25%, there is severe pulmonary hypoplasia, and that means that their mortality rate increases. If there is liver herniation, as I've said to you, unfortunately, if there is a right-sided CDH, it is the most reliable and biggest indicator of a poor prognosis, okay? And unfortunately, depending on where you are and what studies you read, the prognosis for a right-sided CDH can be as low as 20% survivability. Mine, of the ones that I've done, is 50%, okay? So half of the babies that I've done with a right-sided CDH have survived. Of all the babies that I've done with left-sided CDH, 90, I worked it out the other day, it was 89.6, so let's call it 90% of them survived to discharge. So, and this is at a government hospital, brilliant government hospital, Chris Harney Baragwanath, when it comes to pediatrics, especially when I was there, and when my surgical colleagues and some of my anaesthetic colleagues were still there. We had a wonderful pediatric department, and we really worked hard to save these kids. And then the last thing you need to consider the impact of early diagnosis. So if we can make a diagnosis before 24 weeks gestation, we can do prenatal treatments. Thaw off the counter. Sorry, that's my cat. So if we do a diagnosis before 24 weeks, then we can start to do prenatal treatments, so in utero treatments, and we have a plan from the minute the baby is born. Delivery by Caesar on X date with anaesthetist in the room, ped surgeon in the room, ENT in the room if the airway is a problem, etc., etc. And then the last thing that can provide valuable information is measuring lung volumes on MRI. And this is a new instance. So in my day, okay, not that long ago when I was in state, and we were doing lots more of these, we weren't often doing MRIs on these babies, and we certainly weren't doing very many in utero fetal MRIs. Now that we're doing them commonly, again, where I do my list at Park Lane, radiology, we get so much more information. You can see the lung tissue. You can. Thank you so much for paying attention and watching so far. The episode is not over. There is still a full hour left of brilliant practical advice from Dr. Tristan on fetal surgery, the in utero and postnatal management of CDH, as well as a comprehensive plan for anaesthetic management of surgical correction. Please use the QR codes. All of the content in full is available on Patreon. And for more information on who I am on the channel and for more free content, please follow me on YouTube or TikTok. I appreciate your support, everyone, and I will see you a little bit later for our incredibly entertaining and interesting episode on tracheoesophageal fistula, and I tell my famous story of the tetralogy with a TOF. Thank you.